Morning, Ben. Morning, Fran. Just to say to Dave and Kim, Ben and Fran are two of my new team, popped along this morning just to bring them up to speed with the work that we're doing.
Well, thanks, Sean. I'm just keeping an eye on who's joining. Should we give it another 30 seconds or so and then get started? Has the recording started, Elise?
Yeah, that's on now.
Okay, brill. Let's get going then. Hi everyone, big welcome to today's show and tell. We're going to be talking about the work that's taken place through CDPS to support the children's neurodiversity services. So thanks to everyone for joining us. We know how busy everyone is, and as we just said, we are recording this session so we can share afterwards if anybody wants to pass it on to any of their colleagues. So can everyone see the screen okay? Yeah. Okay, good. Okay, so the focus of our work has been something that I'm sure we all care an awful lot about. How do we give people working in our ND teams more time to do the work that actually matters? So that's supporting children and families instead of chasing admin and navigating the complexity of many technical systems. We were asked to explore whether additional digital tools could help reduce this admin burden, and ultimately then would that bring down the waiting times? And as you can imagine, what we found was more complicated than a yes or a no. So today we really want to take you through the work, what we saw, what we learned along the way, and what we're working on now that we really do think will make a massive difference. We've got time for questions at the end, but we do have so much to share with you all and a very short period of time in which to do it. So we're really happy to follow up afterwards if anybody wants any more details. You'll hear from a few of us today. So I'm Kim, I'm the delivery lead on the project from CDPS, joined by Dave, our service designer, also from CDPS. We have Sean, who's been our SRO for the majority of this work, and one of our brilliant colleagues, Kath, from CumTAF Health Board. She's going to join us, and she's been closely involved throughout this work as well. So I'm going to start by handing over to Sean for a little bit of background.
Morning all, and just for people to know, I'm Sean Lewis. I am now Head of Service for the National Neurodivergence team, but when we started this programme, I was Programme Manager for the Neurodivergence Improvement Programme in Welsh Government. To say I am excited about this project, so sorry. It's not normally me, not normally very nerdy, but absolutely, this work is absolutely fantastic and hopefully really groundbreaking. It started off many years ago, recognising it comes out of the Together for Children and Young People work, that neurodevelopmental work stream that occurred many years ago now, and really started to identify that we need to work differently. We did run an initial pilot. One of the challenges of that pilot was that we didn't get enough engagement and not enough thought was given to working with individuals with lived experience and to really understand the problem from their perspective. What challenge are we trying to solve from their perspective? So not just about easing the administrative burden for professionals, but how can we make the system easy to access for individuals with lived experience? Our fantastic digital policy team in Welsh Government advised us to go back to the beginning and work with the Centre for Digital Public Services, who've been absolutely fantastic in supporting us with this work and taking this project forward. And it was really about that research, about understanding what the problem is that we are trying to solve. And it became very clear very early on from a lived experience, a professional perspective, that we are just running to standstill. That a huge amount of time of clinicians and administrators are spent churning over the same really useful information, but regurgitating it from the referral to the assessment into the report. And through the work that we've identified, we've really started to think about what can we do differently with existing resources? Are we really using existing resources in the best way that we can? What more can we get out of those? We've exploring what systems that we currently use and how we can use those better. Our thanks to Hywel Dda and other health boards to help us think about that and what we can do differently. And we've also been exploring, CDPS have been exploring for us, what's already out there, what currently exists on the digital market that can make everyone's lives easier. I know myself, the administrative burden in the assessment process, having worked in the integrated autism service, we wanted to know what was out there. And this has been a fast-paced market, and things have been changing as we've been doing these projects. And it's been really helpful to understand what we need from a digital perspective, where the pinch points are in the system, which we'll go into, and whether or not there's a system that's currently out there that can do all of it, or do we need to chunk down the problem to different bits and get different solutions at different times. And it's been fantastic to work with CDPS to really start to explore that. And I'll hand over to Dave, Kim, is it, to go through the next steps that we took.
Thanks, Sean. So where do you start with all this work? So we knew there were 7 health boards across Wales, and there were lots of systems that were either mandated or people had to use in different teams, such as Welsh PARS, Welsh Clinical Portal, and WICIS. So we wanted to look at this from a human perspective. What does that neurodivergent pathway look from end to end for the people doing the work on the ground? Where are the pain points? Where are the opportunities? So we built on previous research. We interviewed clinicians, service workers, support team workers, and we looked at the pathway from I think I'm neurodivergent to I've got a diagnosis, and we looked at everything in between, and we mapped out pain points, communications, tools used, and we looked at innovation as well. So some of the innovation was very much people-centered, which you might not be surprised about, and it was about meeting the child's needs really early. We saw clinicians setting up workshops to speak to parents and carers early on so that they felt heard. There were support hubs. And they started to move people closer to the patients by doing assessments in schools, fast tracking less complex cases, and for the more complex cases, just making sure that they had those experienced, specialised clinicians who could help get to a decision earlier. And surrounding all this was the challenges that the clinicians had in the systems that they were working in. And this is a quote from one of the clinicians who spent so much time writing notes than actually working with children. And we heard that 10 years ago, it used to be 80% of the time was with children. Now it's 20% of the time. So that's really flipped around over the years. And part of this reason is that there's a lot of disparate information spread across different systems where clinicians almost describe themselves as being detectives to try and find the information, to remember where it was stored. So we needed to understand, we had a broad understanding across different health boards, but as you can imagine, they're working in different systems, they've got slightly different software. So we wanted to go a bit of a deeper dive into an individual health board to see that complexity firsthand. And in that health board, we wanted to see people on the ground using those tools and systems so we could assess, like, if we did introduce a new digital tool, would that actually save them time? And when we arrived at the health board, we saw big screens with lots of tabs open, lots of spreadsheets, lots of different bits of software. We saw notes describing how to do things, where to find things, filing cabinets with letters all nicely, neatly folded, ready to be sent to parents and carers. And part of this is put on the teams that there's something called Conway's law, where the structure of the software will mirror the structure of the organisation that built this. And this particular health board, because they were under CAMS, they had to use another mandated system to make sure that the information was spread across CAMS as well as the ND teams. And the systems a lot of the time seem to be set up for reporting. We had to feed the system, add data in as a clinician, 3 or 4 systems to produce these reports. And it was, in some cases, the systems weren't set up fully, either because the functionality wasn't there or they wasn't configured correctly, which meant that spreadsheets needed to be used for reporting to sort of like fill in the gaps between what the system didn't do. And this is a direct quote from a clinician, and this is what it all leads to for the end user, trying to fit everything together. That I still can't remember all the IT systems I've got to add to. I forget because there's just too many things to duplicate. And all this just leads to huge data redundancy. We counted one patient's name being copy and pasted into 9 different spreadsheets and systems. And then therefore there's huge staff burnout, high attrition rate, because people are trained to try and help these children and they're held back by this ecosystem of systems and tools. So our assumption was that if we thought about adding a new digital system to all the other systems, it wouldn't just be the case that it solved the problem because we couldn't change the entire system. We'd still be mandated to use different tools for the reporting aspect, and we'd be adding on top of this, so we'd only make a small slither of the journey better, but it'd be adding to it because we need to add to all the other different systems as well. So we started to think, well, how could we help teams effectively without adding to this data redundancy issue?
Okay, back to me. Pivot. So yeah, as Dave said, as we got deeper into the work, it became really clear that there was going to be no silver bullet to fix everything, with the reality of all of those mandated systems and the fragmented tools and the very stretched nature of the teams. Dropping something in, it's just not going to be helpful at the moment, another big end-to-end solution. So we pivoted our thinking and we asked ourselves, what's the most helpful thing we could do, not in an ideal world, but in this world, that isn't big transformation, but is small specific improvements focused on addressing some genuine pain points. And one of the most promising opportunities we saw was around note-taking. So what if we could give clinicians time back and help with the burden of that documentation? So we started looking at something called an AI scribe. So an AI scribe, if you haven't come across one, it's like a digital assistant that listens to conversations and it generates structured, accurate notes in real time. So this isn't about replacing clinical judgment, it's about reducing that overhead so people can focus on the important parts of the job that only people can do. This is a very high level sketch of what it might look like. So on the left, you can see we've got this fragmented landscape of information with notes and records spread across, as Dave described, in lots of different places. This makes it really hard for clinicians to know, like, do I have the full picture? And if I don't, where do I go to find it? So pulling all this information together is really time consuming, it's difficult, and we heard about these pain points lots in our research. And we also know that a lot of time is required to write up the notes of any clinical assessments or any time spent at all with patients. So we think the benefits that an AI scribe could bring are time saved in writing up those assessments, time saved in working through information provided by other sources, and we think it can help hugely by reducing that cognitive load on the people in the team as a result. It also seems like it's going to be really helpful when something is missing because it flags it straight away. So rather than having to trawl through to make sure you've got everything, it does that job for you. Sorry, just moving on. So we did some really detailed mapping out of what how a scribe could slot into the process. We looked in detail at a tool called Heidi. I think we're going to share a link. You can log on to that for a trial free period and test it out yourselves at home if you want. So we really wanted to understand where it could actually save time without adding any more friction. This is theoretical, but we did use our service map to examine the real stages of the journey and real tasks. So on paper, we tested this scribe against actual user needs. So as you can see, this looks fairly impressive, and it was definitely worth us following up with more investigations. And to try and bring it to life a little bit more, so based on One Health Board's numbers from last month, where 130 assessments were completed, if an AI scribe can save around 5 hours per assessment, that's potentially 91 working days across the life of those assessments. So that's what we really mean when we say the size of this prize is real. So initially we focused on a tool called Heidi, as I said, but we spoke to a guy called Chris from Neath Port Talbot, and Chris and his team are really evangelical about a tool called Magic Notes, and they're so passionate when you hear them speaking about the benefits that it brings. So it's not just time saved, it's the quality of what's produced, but really importantly, it's the positive benefits that it's bringing to the team. They feel very much more connected with the service users, and ultimately they feel like they're doing a better job for people. So we spoke with Magic Notes, and we started to look what a pilot might look like and what it might cost. And with some fairly heavy duty bargaining, we at CDPS we're going to fund a pilot at Cwmtaf Health Board for £3,000 rather than the standard 15,000 that they charge. We really wanted to mention that in all of this work, we've formed a mini community of practice. That's and that this is people who've been really interested in what we're doing. And just to say, we wanted to say thank you, because the people in the community of practice have been open, honest, and given us really great insight. It's been really phenomenal getting to know them and working with them, because we know how stretched they are, and we're really grateful to the time that they've made for us. And within that community of practice, we've designed a set of experiments that we're going to run as part of the pilot. We definitely want to do the least to learn the most. So we want to start really small with as little disruption to the team as possible, but we need to learn enough to know if the next steps are worth taking. So with that in mind, I'm going to hand over to Kath, who's hopefully on the call, who's going to say a few words about why she was so keen for her team to be involved.
Thanks, Kim. Yes, I am here. I know I've only got 2 minutes, so I'm going to be really fast. I think, first of all, seeing the demo. So I've seen a couple of demos now where Magic Notes have basically taken a couple of us in a role play situation. One of us has been the clinician, one of us has been the parent, say, just for a couple of minutes. We've sort of rolled through some of the, typical case history, the start of that. 3, 4, 5 minutes, so nowhere near the sort of the full time, but just as an example. And then the Magic Notes guy, his end has pressed, stop and summarize or whatever the button says, and the report basically that comes up from that conversation has just been absolutely perfect. So I think it even spelt our names right, which, my name's Kath, it could have been with a C, but it was all that sort of stuff. And I think the guy's first question was, how do you feel? And I thought, I'm gonna have to try not to cry here, because it just seemed so revolutionary, really, in terms of the demands. So I think in terms of the value, we've spoken a lot about the time savings. I think, for lots of clinicians on the call, or even people who are in charge of clinicians' job plans, often in ND services, you've got a clinical session in the morning and the whole afternoon is admin. And I know some of my clinicians don't get their reports done in that time because a report might take them a couple of hours. But I think knowing that as a clinician, by the time that parent and child's left the room, your report might be 80 to 90% done, is just amazing. And it could be 10, 15 minutes reading through and moving things around. So from our health board's perspective, we're really keen to make a start. Clinicians are really, really keen. They've needed no encouragement at all to get on board. So that's amazing. And I think people are, the bit that clinicians like doing is seeing the kids, isn't it? None of us like sitting there for hours writing the reports. And I think sometimes that's what has actually probably made clinicians leave ND services in the past as well, that it doesn't feel like you're a therapist anymore, or what we've trained to do. I suppose the beauty of it for me, that Kim and Dave have alluded to, is that it doesn't have to be an amazing system that takes over everything else. It's a standalone system that really is just writing your reports for you, and then you can copy and paste that into Welsh PAS, Welsh Clinical Portal, whatever you're doing already. So I think that's one of the main benefits of it, actually, really, for me, is that we don't have to do a huge amount of thinking around it. So yeah, from a health board perspective now, it feels like we're really close to maybe getting our risk assessments and our DPIA and that sort of thing signed off, and then hopefully we can run this small scale pilot with a couple of our clinicians over a couple of weeks, and then be able to report back on how we found it, time savings, etc., really. So yeah, thank you very much.
Thank you, Kath. Okay, so what's next for this team? So as Kath said, in Cwmtaf, the team are chomping at the bit, like holding them back at the moment. The legal paperwork's in motion. We're working really closely with the team to get the right approvals are in place, and then once that's sorted, we'll run the pilot in a live clinical setting with the right guardrails. We also want to do some technical testing with the support of Rupa and her team. We want to do testing that lets us safely explore technical hitches, you know, for example, how the tool copes with something unexpected happening, such as a child running to the other side of the room. We really want to know what all those red lines are when we make any recommendations on usage. We want to learn what works and what doesn't. You know, it isn't just to prove that something it works, it's to learn quickly and honestly about what helps and what doesn't, and therefore we know where we can go next. CDPS are going to provide hopefully some clear recommendations on where and how to use a scribe. We also want to provide any evidence and insight for any health boards that come behind Kath and her team to do any future pilots. I'm going to pass over to Sian now, who is going to wrap up for us, and hopefully we can still squeeze some bit of time in for any questions.
Thanks both. What's next overall? I'm confident that AI scribe, I'm confident that the small scale pilots that Kath and Cwmtaf are going to enter is going to make a difference to the way we work. And I think this has the potential to make a huge difference to neurodivergent services across Wales. Reducing children's neurodevelopmental waiting times is a key priority for the Minister for Mental Health and Wellbeing. She is also our digital lead. This is absolutely where we need to be investing our time, resources. We need to move towards a bigger pilot to get real proof of confidence and competence, and to ensure that this does work in the way that we think it works. But I know as an adult clinician, this isn't just going to work for children's neurodevelopmental services. This will work for the integrated autism service. This will work for the future of adult ADHD services. It is genuinely groundbreaking and will ensure that more children and adults will get a robust, high quality assessment in the future. We're going to need more support to move to a bigger project. That's our call out this afternoon. Once we've got the evidence that we need, that we're able to continue with the next step for this project to roll out a much bigger scale project before the end of the year. So a call out to anyone who can assist us on that to take it forward. Thank you all for listening.
Do we have any questions? I can't see the chat. I'm going to stop sharing. Thank you, Myra.
Sally has a hand up, Kim.
Sorry, I can't see. Thanks, Ed. Sally?
Hello, I'm Sally Rees. I'm the new head of the ND policy team. I've just really started getting to grips with all things neurodivergence. Previously, I was head of evaluation new models of care within the Regional Integration Fund. I'm still carrying over some of that role. My question is particularly around Heidi and magic notes. I'm assuming there's something similar. So have you done sort of a comparison and the differences in terms of use prior to the pilot in CTM?
So what we are trying to do is make sure that any experiments that we're running and the pilot that we're running is agnostic of the tool. Obviously, we're using magic notes for that.
Yeah.
But what we want to try and prove is the success or failure of an AI scribe. And I think there will need to be some work done to do some supplier evaluations and comparisons. But but really we're just proving its value before we take that next step.
I'm like Sean, I'm really enthusiastic about it. I think it's an excellent way forward. So I really look forward to the outcomes of the work that's going on in CTM, and really pleased that clinicians are sort of all for it. And hopefully it will make their lives easier, but also the families that are coming in for assessment.
Yeah.
So thank you.
Thanks, Sally. Did you say Glyn, Ed? Yeah, Glyn?
Yeah, hi everyone, brother. Glyn Jones, Chief Digital Officer, Welsh Government, also member of the Health and Care AI Commission. So I just, it all sounds really exciting. I think it's really important, you show the graph about time saved, that we understand the quality of the outputs as well. And I know you've sort of said that, but I feel that that's just as important as time saved. And I was really pleased you mentioned at the end, the work you're doing with CTM to do the necessary approvals and the clinical approvals, because we don't want to lose that aspect. So I suppose, so turning that into a question, do you feel you've got enough? Because obviously through the AI Commission, we've talked a lot about the guardrails and the guidance to support implementation of AI in health and care. Do you feel you've got enough clarity on the steps you need to take through privacy impact assessments, ethics assessments, clinical assessments to help you through that journey? And if not, is that that's hopefully something we can learn from? Thanks.
Yeah, I think we are learning. We do have the support of Rupa in our team, and they're being really helpful for what we need to consider. And I think what we're really hoping is, although it's proving fairly lengthy process at the moment with ComTAF, that it will be very helpful to then share that with other health boards, so that we can kind of we've got a good place to start.
I think so. You just made a really interesting point there, where you're saying you hope it will make things easier for the other 6 health boards. We know from experience that isn't the case. So I think if we're ambitious enough to think that this could scale, then I know there are some colleagues from other health boards on the call today. I think it's worth thinking about that as soon as we're ready to start thinking about those things, to get an understanding from the other health boards on what would give them enough assurance to help them make that journey as quick as possible. We have discussed other examples of the Commission where we've got 7 boards essentially going through the same processes 7 times. So we'll all want to see pace if this works. So yeah, I think that's a really pick that up with Rupa as well. Thanks.
Yeah, I think just to follow up on that, Glyn, as well, so the community of practice at the moment is team managers and clinicians, but it's almost like we need an extra string to that, where we're talking about the information governance teams and what they can learn from working together. So yeah, it's a really good point. I can't see anyone else's hand. Ed, is there anyone else?
I was just going to follow up on what Glyn had said, that it's interesting because it's in things like Heidi are in use in GP surgeries in Wales already. So it sort of feels from a healthcare perspective that there's probably some of that work that's been done within healthcare, not necessarily within the health boards, but there's probably something that we can learn there as well, potentially. Yeah.
I think someone just had a query on who Rupa was.
Oh, Dave, do you remember her job title?
Kim, shall I come in?
Yes.
Morning, everyone. I'm Leanne Roberts. I work for Rupa in Welsh Government as part of Life Science and Innovation. So Rupa is the DD for Life Science and Innovation, and this is something we're really keen on exploring. So we've been speaking to Dave and Kim about this project, and we're, the role that Rupa and I can play this is in terms of we can link in with the innovation leads in the health boards and try and sort of ease the wheels in terms of trying to get the IG information, that sort of side of it wrapped up as well, as well as trying to promote this further through the other health boards. So if we do get, so if we can get some more buy-in from other health boards outside, CTM, that's something we will try and achieve as well. So that's so we are in Welsh Government.
Look at that perfect timing. It's as if we planned it. Just to say, I think there'll be a further show and tell probably in the middle of September at some point. So we'll send out some comms about that. If anybody wants to chat with us, please do reach out. And if you're interested in joining the community of practice that we've got going, that would be great.
Cass just put her hand up, Kim.
Oh,
yeah, sorry. Have we still got the AI scribe meeting after this? Or
no,
is this instead of?
This is instead of Kath.
Yeah, great. Okay, lovely. Thank you.
Thank you, everyone.